topical medical management. And as you know, this is an educational venture that we're performing to empower female voices in phlebology, vascular and endovascular surgery. So before any further introductions, what we'll do is ask the technical team to provide us with the videos from Drs. Kavnik and Kanata, who are supporting this initiative. If we could please run the videos.
Buenos días, queridos amigos. Yo soy el Dr. Víctor Kanata, presidente de Venous Lymphatic University. La plataforma y el grupo de trabajo de Venous Lymphatic University es un grupo de profesionales de alto nivel a nivel mundial que se encuentra desarrollando programas de enseñanza, de capacitación y de preparación de diferentes tipos de webinar, trabajos humanitarios y enseñanza en el campo de las varices y los linfáticos. Este grupo de trabajo tiene una calidad y una capacidad excelente. Nos encontramos permanentemente trabajando en demostrar la excelencia y la capacitación de todas las personas dedicadas al tratamiento de las varices y de los linfáticos a nivel mundial. Por eso les decimos y les agradecemos al grupo de trabajo. Les pedimos que nos sigan en nuestras plataformas, en nuestros diferentes webinars, y que se acerquen al grupo de trabajo de Venous Lymphatic University. Generalmente lo manejamos en forma compleja, teniendo la posibilidad de demostrar el trabajo de las diferentes diversidades etnológicas, demostrando las capacidades científicas a nivel mundial. Así que por tanto les doy la bienvenida y espero que nuestro trabajo tenga sus frutos en relación a la capacitación, la calidad de la enseñanza y así como también la llegada a nuestros diferentes pacientes a nivel mundial. Así que un fuerte saludo para todos. Por favor, recuérdense de que la capacitación y la enseñanza es algo que realmente nos va a ayudar y va a demostrar que nuestros pacientes cada vez reciban mejores diagnósticos y mejores tratamientos en el arte del tratamiento de las varices y los linfáticos. Un saludo para todos y que Dios los bendiga.
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kavnik, and I'm the chairperson of Venous Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled Empower Her, which was developed by Ruth Bush, Sarah Onida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
Right, so today our session is on medical management, which is certainly a point of interest for me. I'm Sarah Onida. I'm a clinical lecturer at Imperial College London, and therefore in a country where we don't often use medical management in the UK. So I'll be really interested, and I'm very, very pleased to have our panelists today. Dr. Reachi, who is a vascular and endovascular surgeon and angiologist who works in Mexico, and Dr. Gloviczki, who is a Mayo Clinical Research Fellow and Collaborator Emeritus. And I am just going to very briefly share my screen to, first of all, thank both Boston Scientific and Medtronic for their kind support of our initiative. And as mentioned, today we will be really looking at medical treatment. So without further ado, I would be very grateful if the technical team could play Dr. Reachi's presentation, which is the one we'll start with. Thank you.
Good morning. I'm going to thank Dr. Victor Canata the invitation to participate in this webinar. I am Dr. Rebeca Reachi. I am a vascular surgeon from Mexico, and I'm going to present the medical management in chronic venous disease. I have no disclosures. Like we all know, venoactive drugs includes an heterogeneous group of drugs. Most are plant origin and some are synthetic. We have 5 main categories, and some are commonly taken as a mixtures. 2 additional drugs that are not venoactive, like pentoxifenone and sulodexide, are included in these guidelines published in 2018 because of their beneficial effect on the healing of venous leg ulcers. We have 5 main categories of venoactive drugs. We have flavonoids, alpha-benzopyrenyls, saponins, other plant extracts, and synthetic products. In the category of flavonoids, we have the MPFF, that is the micronized purified flavonoid fraction. We have diosmine, we have rutines and rutosids. In the category of alpha-benzopyrenyls, we have coumarin. In the category of saponins, we have horse chestnut seed extract. In the category of other plant extracts, we have ginkgo extracts like ginkgo biloba. In the category of synthetic products, we have calcium dibenzoate, benzarone, and naftazone. About the mechanism of action, not all the actions of venoactive drugs are fully understood, but it seems clear that they can act at both macrocirculation and microcirculation levels, affecting the changes in the venous wall and venous valves that lead to the development of venous hypertension and altering the effects of venous hypertension in the small vessels that lead to the venous microangiopathy. Traditionally, venous hypertension was thought to result of primary from valvular incompetence related to excessive venous dilatation due to the weakness of the vein wall and low venous tone. To know when venoactive drug is indicated as a medical management, we have to know the pathogenesis of chronic venous disease, that it's a result of chronic venous hypertension of the lower limbs, mostly due to reflux through incompetent valves in the axial or superficial veins, or perforate valve incompetence. However, venous hypertension can also be due to obstruction of venous outflow or failure of the calf muscle pump. Venous hypertension is thought to lead to various signs and symptoms of the chronic venous disease, principally by inducing chronic inflammation and possibility by altered shear stress or inducing hypoxia. Chronic venous inflammation leads to destruction, structural change, and hypertrophy in the vein walls and tissues due to leukocyte infiltration and activation of inflammatory mediators, and the action of the extracellular matrix degrading enzymes like MMPs and productions of transforming growth factor B, which may cause fibrosis. These structural changes result in vein dilatation, which leads to varicose veins, reticular veins, and telangiectasis damage to the valves, creates a vicious cycle of worsening venous hypertension and disease. Flavonoids appear to act in chronic venous disease primarily by inhibiting inflammation, and they can also improve venous tone, which may help counteract the formation of dilated veins. In this schematic representation of the interplay of the pathophysiological mechanisms contributing to the chronic venous disease development, like predisposing factors and such as female sex, pregnancy, family history, obesity, sedentary lifestyles, and occupations can lead to the hemodynamic abnormalities in the veins of the lower legs, which may or may not proceed by venous valve dysfunction, elevated venous hydrostatic pressure, and low shear stress, lead to increased venous wall tension and distension, followed by activation of the matrix metalloproteasas, through upregulation mediated by hypoxia, inducible factor, and transcription factors. MMPs contribute to degradation of the extracellular matrix and vascular smooth muscle cell. Relaxation through release of endothelium-derived hyperpolarizing factor and inhibition of calcium mobilization, and further other venous wall dilatation. This results in leukocyte infiltration and activation, setting up a pro-inflammatory environment with the vein wall, which in turn leads to further vein wall degradation. So consequently, much of the early research on venoactive drugs was centered in their effects on venous tone. More recently, research interest has shifted towards the action of venoactive drugs on chronic inflammation processes that can affect large and small venous vessels and valves. About the evidence-based modes of actions of the main venoactive drugs, we have that in the category of flavonoids, the MPFF, they have effect in the venous tone, venous wall and valve, capillary leakage, lymphatic drainage, embryological disorders, and free radical scavengers. About the alpha-benzoprenols like coumarin, we have that they have effect in the capillary leakage, the lymphatic drainage, and about the saponins, the horse chestnut seed extract, they have effect in the venous tone, capillary leakage, and free radical scavengers. We don't have any data available about ginkgo extract, benzarone, and naphthazone. We have about the synthetic products, the calcium thioacylate, they have effect in the venous tone, about the capillary leakage and lymphatic drainage, embryological disorders, and free radical scavengers. We need individual evaluation of the disease severity. The symptoms of chronic venous disease can be a daily challenge for the patients and can be measurable to decrease the quality of life. Symptoms also limit the ability of the patients to participate in social, physical, or occupational activities with financial consequences due to the loss of work, time, or disability. Chronic venous disease quality of life questionnaires like CVID-20 and CVID-14 have been validated in multiple countries and have been shown to be sensitive indicators of the change in chronic venous disease symptoms. About the CVID-20, they measure the impact of the patient's life, like pain in the legs, pain during the work or sleeping problems, the physiological function and social activities like walking, doing some exercise, traveling by bus or dancing, and the physiological dimensions like feeling shy to show your legs, feel tired or feel depressed. About the pharmacological effects of venoactive drugs and benefit, we have that MPFF improves chronic venous disease symptoms like rhodosids, calcium thioacylate, and sulodexide. The ones that reduce like edema is MPFF, rhodosids, and calcium thioacylate, but only MPFF and sulodexide, they improve quality of life, that it's very important for the patient. Now we are going to talk about the strength of recommendations for these venoactive drugs. We have that for MPFF, they have a strong recommendation for the treatment of pain, heaviness, feeling of swelling, functional discomfort, cramps, leg redness, skin changes, edema, and quality of life. And it's weak for paresthesia and burning. For Ruscus, it's strong for the treatment of pain, heaviness, feeling of swelling, leg fatigue, paresthesia, and edema, and is weak for cramps and pruritus. For oxyroutines, it's strong for the treatment of pain, heaviness, and cramps, and is weak for edema. For horse chestnut seed extract, it's strong for the treatment of pain, pruritus, and edema. For calcium thioacylate, is weak in the view of possibility of inducing granulocytosis. My conclusions are that venoactive drugs may be used to relieve chronic venous disease-related symptoms and edema in patients at any stage of the disease. That means C0 to C6. MPFF and sulodexide are recommended in international guidelines for the treatment of chronic venous disease and venous ulcers, but MPFF is the only one to obtain a grade 1B based on the strong recommendation for use and moderate quality of evidence in the relief of symptoms associated with C0 to C6. MPFS and sulodexide are also recommended in the clinical practice guidelines issued by the Society of Vascular Surgery and the American Venous Forum. The improvement of symptoms is associated with the improvement of venous tone, flow, and into the microcirculation, and decreased capillary permeability. The combination of venoactive drugs and elastic compression increased healing of ulcers. The use of venoactive drugs plus interventional procedures in patients who needs it has been proven to be beneficial to the patient. These medications have excellent safety profiles. Further experience and controlled clinical investigation of venoactive drugs is likely to prove additional clinical evidence to better define the therapeutic benefits. The potential danger is to encourage general practitioners to prescribe venoactive drugs based on the symptoms alone without considering the status of the patient and ignoring the indication for appropriate investigations that could lead to effective intervention to relieve symptoms and arrest progression of the disease. Thank you. Good morning.
Excellent. Well, thank you very much for that really insightful presentation that I was very pleased to see included quite a lot of basic science, which is always obviously very important, but also highlighted the quality of life issues for these patients. And I think because Dr. Gloviczki is going to be talking about the venous leg ulcer side of things, perhaps we can progress that presentation next, and then we can have a bit of a longer Q&A with both of your expertise once we finished with the presentations, if that's okay. So if Dr. Gloviczki would like to share your screen and present, that would be lovely. Thank you.
Okay. So I think we should be good, and I will just start the presentation. Okay. Yeah, that's fine. So good morning, everybody. And thank you very much for your kind invitation. As for my disclosures, I'm a Chief Scientific and Clinical Advisor to Vita Support ND company. Venous leg ulcer remained an unsolved medical issue. Despite a certain progress in ulcer knowledge and treatment, reported prevalence and incidence has no tendency to decrease, as shown, for example, in the Olmsted County epidemiological studies. The classic cascade of events leading to venous leg ulcer includes venous hypertension, chronic inflammation, edema formation, and skin changes. The initial understanding of edema formation pathophysiology based on the Starling research was very recently revised with a new actor in the fluid homeostasis rediscovered, the endothelial glycocalyx. The glycocalyx appears as a fine hairs in the luminal surface of the vessels and has an extremely complex architecture. It is involved not only in permeability barrier, but also in the inflammation mitigation and coagulation. Thin or shed glycocalyx is now recognized to play an important role in venous hypertension and associated complications. Glycocalyx caveolae contain endothelial nitric oxide synthetase, and glycocalyx components transform the mechanical signals of luminal shear stress into biochemical signals, activating enos to produce nitric oxide and decrease reactive oxygen species. Shedding of glycocalyx results in uncoupling of the enos, decrease of the nitric oxide production, and increased oxygen species production. All this ultimately contribute to cardiovascular diseases. One of the factors of ulcers non-healing is associated with methylene tetrahydrofolate reductase abnormalities or its source product deficiency, such as dietary folate or vitamin B. The shedding of the glycocalyx results in the leukocytes activation in addition to the endothelium, with increased cellular oxidative stress, inflammation, and vascular permeability, leading to the interstitial edema. Wound care, local care and compression therapy are well established basis of treatment for venous ulcer. For compression, however, poor acceptance of high degree compression is an issue. Combined treatment showed a better healing rate and healing time. However, some ulcers are still difficult to heal, and recent discoveries enhance the concept of adequate nutrition. SVS and AVF venous leg ulcer guidelines also recognize the value of systematic components with recommendation grade 1. 2 substances were admitted by the guidelines committee, pentoxifylline and MPFF. MPFF is composed in 90% by diosmin and in 10% by hesperidine fraction. The macronization process almost doubles interstitial absorption and then therefore increases the treatment efficacy. The effects of MPFF are mainly related to the mechanism of action as inhibitor of cell adhesion molecules with NADPH oxidase inhibition and decrease in reactive oxygen species production. It translates into clinical benefits with reduced leukocytes adhesion inflammation, reduced microvascular permeability, reduced edema, improved venous tone, capillary and lymphatic function. In venous hypertension and inflammation, MPFF demonstrated significant improvement of the microcirculatory changes in a model of venous hypertension. Clinical study showed that MPFF significantly improved the venous tone. MPFF reduced venous reflux time in the randomized double-blind controlled versus placebo trial in patients with edema. MPFF treatment significantly decreased the level of vascular endothelial growth factor, reduced cell adhesion molecules, and mitigated the inflammatory reaction in a dose-dependent manner. Another clinical study in the women with varicose veins demonstrated the decrease in levels of pro-inflammatory cytokines. One interesting study revealed increased oxidative DNA damages in lymphocytes from CVI patients compared to healthy controls and a beneficial effect of MPFF. Coming back to the glycocalyx function, potential impact of MPFF could be related to the antioxidant effect with decrease of oxygen species and increase of nitric oxide. An in vivo model of hamster cheek pouch allows a direct observation of the microcirculation. In this model, MPFF anti-hyperpermeability effect was significantly higher than that of diosmin. Anti-edema properties of MPFF in chronic venous disease were demonstrated in several double-blind placebo-controlled studies. These trials were recently part of a systematic review and a meta-analysis. 7 high-quality trials were included in the meta-analysis, and the author concluded that based on high-quality evidence, MPFF is highly effective in improving leg symptoms, edema, and quality of life in patients with chronic venous disease. In a venous leg ulcer, 5 randomized controlled trials were conducted with MPFF as an adjunctive component to standard ulcer treatment. The meta-analysis reinforced the existing evidence on MPFF therapy benefit in terms of ulcers healing rate and shorter time to healing. Here is the example of patients with large ulcer of venous origin treated with local wound care, compression, and MPFF. In addition to all this data, what was found that MPFF adjuvant treatment is not only effective, but also cost-saving. In conclusion, new discoveries in ulcer pathophysiology attributed a special role to glycocalyx and endothelial NO in venous disease and leg ulcers development. Nutritional supplements in general are indicated for patients with vitamin mineral deficiency, and adjunctive treatment with pentoxifylline or MPFF for venous leg ulcers is recommended by SBS AVF guidelines. MPFF is one of the most studied and frequently used compounds for treatment of chronic venous disease and venous leg ulcers in particular. MPFF reduces edema by improving venous, capillary, and lymphatic circulation, increasing venous tone, and decreasing inflammation. MPFF improves venous symptoms, patients' quality of life, as well as skin changes and venous leg ulcer healing. Thank you very much for your attention.
Thank you for another fantastic presentation, which is, again, very, very insightful. So we've got the luxury of quite a stretch of time with 2 fantastic experts. So I would encourage all the attendees, if they have any questions, to put them in the chat, and then we can obviously go through them. But in the meantime, I'll perhaps start off myself. So Dr. Reachi, as I mentioned, in the UK, we don't really use medical management. None of the medications are licensed as such, so we have very little experience with them. Can you tell me how the use of medical management fits in the assessment and management of your patients with chronic venous disease? Is this something you use with all of them? Is it just patients specifically with edema? What sort of seep stages would most benefit from them? Do you have any comments, and how does that fit in with then interventional management with, for example, endovenous ablation?
Okay, for example, here at my office, most of my consult are women, and most of them, sometimes they come for aesthetic. I mean, they don't have really a bad, they have a chronic venous disease, but sometimes they just come here for telangiectasias. But all the patients are checked by ultrasound, by Doppler ultrasound. And we ask all the symptoms and signs that they have. And based on that, we decide to give them some medical management because some of them, they just come without symptoms. So we know that most of the venoactive drugs are based on symptoms. So if the patient doesn't have any sign, for example, edema, or they don't have any symptoms like pain, like ulcers, like cramps, we just do some pantyhose, some compression stockings, depends on what they need. And if they have some symptoms, where I live, it's very hot on summer and on spring. So like it is very hard. Of the patients have edema. They come always. because they have edema. So for example, we prescribe some venoactive drugs like MPFF or like Ruscus that we have here in Mexico, and compression stocking. If they have ulcers, so we have to change our point of view about venoactive drugs, because sometimes they have infections, so we have to give them some antibiotics, and they have to have some ulcer care, and of course stocking and compression and venoactive drugs is like a whole treatment. We don't have to only think that venoactive drugs are going to heal everything and everything is going to be fine. We have to talk to the patient and tell them that venoactive drugs are for the symptoms, more of them. Now we have new data about they improve glycocalyx, for example, like MPFF and sulodexide, that they improve glycocalyx and they can getting better about the disease. But sometimes the patient thinks that venoactive drugs is the cure of everything, and we have to talk to them and say that it's false, that it's not true. Sometimes you have to talk with them, and some of them, they need surgery. And about surgery, we have here in Mexico, we have thermal and non-thermal treatments. Most of us, we have the vascular surgeons have, we start with laser, with endovenous laser treatments, and we changed then to radio frequency, and now we have MOCA, we have Venosil. So, but these are new. So not everybody knows how to use it. Not everybody can reach it to the cost of the surgery. So if, for example, the public institutions, public hospitals, they don't have lasers, so they are still doing open surgery. So it's different in Mexico sometimes from the rest of the world, because we have we have a lot of treatments nowadays, but not everybody can reach them. That's the sad part of this. We have a lot of venoactive drugs. Most of them we have it here in Mexico. I know that they are not all over the world, but we have a good experience using it, and the patient can feel the benefits of them.
Dr. Gloviczki,
Can I have the question for both of you, actually? I'm very curious to know, how many patients in your practice have the clear lymphedema associated to venous disease. And if there is a case, do you have a specific lymphedema-oriented treatment, such a, the manual lymphatic drainage, or pump treatment with the pressure pump treatment, or other?
Dr. Reachi, do you want to answer the question first, and then I'll give the perspective from my unit?
Thank you. I don't have the amount exactly, but I have my own pumps for therapy, for presotherapy. So I send my patients them to I don't use manual drainage, because here in Mexico, most of the people that made a massage and they can do some manual lymphatic and venous drainage, sometimes they are very rude, and they don't know how to do it. So I prefer the mechanical with the pump. So I send them, and they have a very good results with that. Sometimes I have my patients, I have my own my own numbers, and 90% of the patients, they feel very good and they repeat every month, and they are going to maintain the legs without edema. So sometimes they don't come here to a checkup. They just go there and they ask for the therapy, and they know how to do it. So I have two nurses there that they do the therapies, and sometimes they call me and they just tell me, your patient is again here, and they start the therapy without venoactive drugs. Sometimes they only need the drainage.
I think that's a really important question, because actually phlebology and lymphedema go hand in hand, and there's plenty of even animal studies where if you interrupt the lymphatics, it has a knock-on effect on the veins and vice versa, actually. So they're obviously very closely correlated. I think certainly in NHS practice in the UK, it's very much, the two aren't managed concurrently often. So if we have a patient that comes with symptomatic venous disease and we think they're C3 and they have venous reflux, we will just treat them. They will have a bit of compression post-operatively, but there's no definite regular management of those patients from a lymphatic perspective. And patients that come in with clear lymphedema, then there are very few specialized units that will then concentrate on manual lymphatic drainage and provide that service to those patients. We don't at Imperial. For example, St. George's Hospital has got a strong dermatology and lymphedema service there, and actually often it goes hand in hand in places where you have a big oncological service, because often the manual lymphatic drainage is given to patients with breast cancer for upper limb, and then that's how you try and get in perhaps the lower limb patients. But by and large, you've got few centres that are interested and that do it to a high level, but by and large, those patients, if they don't have access to those treatments, they will largely go into compression. But yes, they're treated very much slightly separately. If we think there's a big lymphatic component, they will have lymphoscintigraphy. They may or may not have intervention if we think it might help, but we don't give a routine service for manual lymphatic drainage or even pumps, to be honest. And the NHS can't supply those. So, there's a funding issue as well from a National Health Service.
Certainly, yeah. Well, these are expensive. That's for sure. This is the expensive equipment.
Indeed. And actually, that brings me to another question, which it'll be my ignorance because I don't use venoactive drugs. But what role do they play in lymphedema? Obviously for the permeability and the swelling. Is there any role? Has anyone ever used them in that context?
Yeah, absolutely. You have MPFF, who is really proven to be efficient in lymphedema, and this not only in experimental studies, which are beautiful because you can observe those lymphangion contracting in the very nicely and strongly in animals treated by MPFF, but also in the clinical studies in the lymphedema post breast cancer surgery lymphedema. There is always an issue, they are as far as I know, there was always an issue to prove for the arm lymphedema, a clear decrease of volume. But what we have in the clinical studies is a tendency to decrease of edema of the volume, and the lymphoscintigraphic parameters all improved. So clearly it works on the lymphatic circulation and improves. But I think that further studies certainly are needed to show a clear benefit for the volume. It's difficult with lymphedema because you have sometimes completely irregular forms, and to really measure precisely the volume, it's not that easy. It's a headache, actually, I should say.
Indeed. Dr. Reachi, any comments in terms of your experience with patients with lymphedema using venoactive drugs?
Yes, not only venoactive drugs. I guess lymphedema is a completely different kind of view, because it's not chronic venous disease only. Sometimes it's complicated with an infection, and then they started edema, and then they complicated with a chronic lymphedema. Sometimes here in Mexico, I study the patients with a blood test. I always ask for proteins in blood, and I found that most of the lymphedema patients has low levels of albumin. That it's very important here in Mexico, because I guess this has to be with the food that we eat, that sometimes they are not in a good nutrition. So like the talk of Dr. Gloviczki said, that nutrition is very important, and sometimes all these talks is about venoactive drugs, and nobody talks about nutrition. So I guess
lifestyle also, lifestyle. Sorry.
And lifestyle, yes, yes, and it's very important. You know, if you are overweight, if you are obesity, and you don't walk and you don't eat like you have to eat, and I mean, everything has to be with the disease. And here in Mexico, we have a lot of problems with obesity, with diabetes, with hypertension, and you know that everything here, besides that, you have renal failure sometimes, and it's not lymphedema, it's renal failure, or it's cardiac insufficiency. So you have to not only base it in that you have to give a venoactive drug because the patient is with lymphedema. You have to check everything in the patient. Sometimes we are the persons who has the obligation, and you have to do it, to check your patient, to ask the patient, and to ask some blood tests sometimes, because it's the first time and it's the only time that they are going to come with you, and you have to be very precise with the treatment that you have to do, and with the words that you have to talk with them, and say that this is not acute, this is chronic, and they need a completely different treatment, starting with food that they have to, and lose weight and do some exercise. And that's the problem here in Mexico. Some of my patients, they don't, because they are obese, they don't move because they have some knee problems, and so this is the chronic thing, because they don't move, they don't do exercise, they don't eat well, so they are gaining more weight, and this is a circle. So you have to break the circle, and not only with venoactive drugs. The venoactive drugs, I said, they're going to have this from this, and they are going to improve the disease. But from this to this, they have to change their lifestyles. So I think this is like a completely different way of thinking about lymphedema and chronic venous disease. Because lymphedema is a disease that the patient has to know that they have to change everything. In chronic venous disease, sometimes when you performance an endovascular laser, they feel so good that they don't come again, because they feel very good. And if the patient goes fine for 10, 12 years, it's fine. But with lymphedema, you have to be very conscious with the patient, and you have to talk with them.
It's a chronic condition, isn't it? And as you say, it's multifactorial, and you can't just do one thing that will improve things. It's and in its ownership of their own disease, isn't it? And the realization that they will need ongoing management, and there is no easy fix. And actually, that's really difficult when you counsel such symptomatic patients with horribly swollen legs, and they're like, why can't you just make them better? And it's constant management. It's something I'll have to manage for the rest of their lives effectively, a little bit like having diabetes or something of the sort. So it is really difficult.
So now I have just one comment and a question for both of you, because the more and more often right now, venous edema is considered like the lymphedema of venous origin. So one of my colleagues is calling that love. Yes, and it's true that whatsoever is happening always with the participation of lymphatic system, and even if the venous disease is at the origin, finally it comes to the point that the lymphatic system is broke because of the overload. So I think that's always the delicate situation. And we were in one moment discussing, in the during the AVF meeting, how in fact unjust it is, because the edema, like in lymphedema post-cancer, is really very seriously considered and taken in medical charge procedures. And in venous disease, sometimes it's not that well followed or treated, because it's venous disease, it's chronic, because patient is coming, having a little telangiectasia or little this, little that, and it's not that seriously considered.
That is, yes, absolutely. Very true. As I said, we sometimes have to try and almost sneak patient into upper limb lymphedema clinics if they're very symptomatic, because they just don't get seen anywhere else effectively, from an NHS perspective. It's very, very challenging. Dr. Reachi, is that similar in Mexico, or do you have more of a targeted lower limb lymphedema service there?
No, we don't have a like that lymphedema service, not in the public, not in the private hospitals or work. So everybody that sometimes the oncologists work with you. Sometimes the oncologist, when they perform, for example, they send to you the patient you have to teach them how to take care of his arm. And the point of view of the oncologist is different from us. Mm-hmm. So they send to me when they have a patient that starts with lymphedema, or they have a lymphangitis or inflammation or infection. So they send it immediately to me, because they know that if you act very early, you have better results than if you do it chronically. I mean, if you have the patient and you take care of the patient since the beginning, if you teach them well that they have to take care of his arm, of her arm, they are going to have a good, we hope that they are going to have a good final. They are not going to be very swelling, and they are not going to have a bad prognosis. So I think this is like a teaching mode, that you have to talk with the patient always, and you have to show them how to take care of themselves, of the skin, of the red dots that they have to know to come here early, and you have to act very fast, avoiding all the complications.
And can I just ask a quick question? Just going back to ulcerations, Dr. Gloviczki, obviously there you presented lots of really interesting data regarding healing and the additional use of medical management, venoactive drugs to compression. Is there any evidence to prevent recurrence, sort of more as a chronic type, preventative measure of venoactive drugs, or has that not been looked into?
There is no study about it. I believe that it has to have the action because certainly, by the anti-inflammatory properties, all the properties concerning glycocalyx and in venous tone and everything, it has to be good for veins, but there is no study with the specific recurrence rate endpoint. So we suppose yes, but no proof.
And I guess it's similar to it's a bit of an echo. I guess it's similar to breast thrombotic syndrome, I guess, as well. So patients have had a DVT and have ongoing symptoms and signs of swelling and sort of really quite florid PTS. Is there any evidence that they're helpful in those patients as well?
Yeah. This is included because actually all these studies that we have, like for example for edema or symptoms, had always the sub population of patients with post-thrombotic syndrome that was included. So we know that it works in post-thrombotic syndrome, but we don't know, for the recurrences specifically. And actually, probably a lot of things are not very well known because I was looking at this data concerning the compliance with the compression therapy. That's terrible. How you can even assess compression treatment if you have such a poor acceptance. It's I don't know how to deal with that because certainly the compression is proven to be very good for ulcer patients and then for edema patients, but you don't have the really sensu stricto perfect scientific proof.
No, absolutely, because no compliance is bad, but even when it is measured, it's measured so differently, and a lot of the studies that use compression don't actually have any objective measure of compression as to what sort of pressure is actually being delivered, so you don't know what degree of compression is there. So is it working, is it not, and is it not working because they just haven't bothered measuring what they're meant to be delivering. It is extremely difficult.
Complex.
Absolutely. And even, we sort of have been thinking about some studies on compression, actually just thinking about the ways around that compression and how to deliver it, and from a funding perspective, making it value for money is really difficult, actually, just from setting up a study.
Now talking about how to get the compression placebo.
Yeah, indeed, and actually
there's no, all these studies were done so-called versus placebo, but there is no placebo. There's no placebo the compression therapy. You cannot say to patients, I will give you the compression and be double blind, because patient knows and you know.
Indeed, absolutely, what the pressure is. What we find really difficult actually is that in the community, and that's relevant to patients, particularly with ulceration, is that we have very little training and skill set actually in the community for new nurses to learn how to deliver compression adequately. So patients often have treatment of venous ulcers mainly with compression in the community for a very long time because compression should fix them, and they have these chronic ulcers and then they eventually make it to hospital. But I think there's a very big problem about the skill set and the available training for local sort of district nurses to be able to deliver compression adequately.
Yeah. And actually, the issue is also I just recently had the series of conferences with the lymphedema patients, and what I really found that most of them cannot use the commercial type of the compression stocking or something, that they truly are improved only with the custom made compression devices. It's compression stockings or something. And it's very costly, certainly, and truly you need a good service of the fitters, not only of the the patient has to be trained and so on. But in the very beginning, you have to have somebody who is a super expert in fitting the custom-made compression.
Absolutely.
So that's an issue here.
Here in Mexico, that's a big problem because when there is a very humidity or it's very warm, they don't want any compression, they don't use it, even that they have edema. So we are fighting against the weather sometimes. And here in Mexico, we have a lot of cities that they are very warm. So it's a fighting with the patient that you have to tell them that they have to use it at least 8 hours, because sometimes they don't want to use it even 1 hour because they say that no, I can't. It's impossible because it's very hot. It pains, it's itching. And we say, no, come on, you have to use it at least 8 hours. And you are right, Dr. Gloviczki. You have to know your personal, or you have to train your nurses to teach them how to use the compression. Because, for example, here in Mexico, I have a store because we didn't have, when I arrived here in my city, there were not compression stockings at all. So I started a small store, and I have to teach my nurses to how to measure the patient, what kind of compression stockings, the quality of compression stockings, that it's very important because, like, you know, there are different qualities, there are different prices. I mean,
Absolutely.
Some of them are very expensive and the patient is not going to use it because they cannot afford it. And some of them, they're very cheap, but their quality is not good. So it's a problem here in Mexico about the economy and everything. And sometimes we have this kind of problems because the public social security, they don't cover this. So they have to buy it. They have to, even if they are public or private, they have to buy it, everything, because any insurance, they don't cover this. So sometimes you are against the patient that they don't want to use it, and sometimes even with the economy, you have to fight against that.
Well, actually, you have to find all over the world. Because I see the situation is exactly the same in the US. And by the way, I'm also in the very hot spot because it's Arizona, so it's close to you, Rebecca. But certainly, and that's what you said, that if they are bothered with the quality of the stocking, they are not going to put it, period. Yeah. So whatsoever money they will spend, that's completely useless. That it has to be really, the patient has to feel comfortable with it. And I'm fighting with this opinion that it has to hurt. It doesn't have to hurt, because if it hurts, patient will not use it. It's much better to have a lesser compression strength, and have a better acceptance of patient and better compliance than have something super strong and the patient will never put it in the drawer. That's it. End of story. Yeah, and the weather is a serious issue, certainly. And I don't know the solution actually for that, except the venoactive drugs. You know, that's why it is so popular here.
Yeah. I think just going back to the point of finances, actually, often patients who end up paying them for it themselves. Obviously, you don't buy one pair, you buy two, and you have to replace the stockings every few months. So actually, it's an ongoing expense that patients have to then face, isn't it? Especially if they just don't want sort of, you know, the green ones that we give in hospital or something a little bit more specific. So no, absolutely, it's really quite challenging, I think, for them. I think we're nearly at wrap-up time. I had just one more question for the both of you, actually. I'm really fascinated by the whole mention of the, glycocalyx and this whole idea that shear stress can then be, so mechanics can then be translated into biochemical signaling. And we know from all the protein work and even the metabolite work that we've done and the genetics that inflammation is the underpinning of all of this, really. Where do you see this going in terms of future research? And do you ever think that vascular venous intervention will become superfluous one day if we manage to get a pill that affects more than one aspect of that inflammatory cascade of the glycocalyx? Dr. Gloviczki first, just for your final comments.
I would say that, if you could manage to intervene with the drugs from or the supplements from the very beginning of disease, it could be maybe possible to avoid surgery, to avoid further complications. But I don't believe that it's going to happen, because this is the beginning of the venous disease are very insidious. So it's coming very slowly, and when the patient is looking for the physician help, it's already progressed to the extent that certainly they would need the ablations, they would need sclerotherapy or another method to manage what already is damaged, because that's the situation. And certainly the drugs, the supplements can improve the situation and can prevent. I believe very strongly in the prevention of the further evolution towards the severe stages. But, if the vein is completely distorted, like you see in these varicose veins, completely, like the tortuous and modified venous wall, I don't believe that any drug can do the miracle and just change it. Not possible.
And Dr. Reachi, your final comments?
I completely agree with Dr. Gloviczki, because sometimes the patient even thinks that with a pill they're going to be fine and that's all. And you have to talk with them and tell them that the pill that disappears of the venous chronic disease is not yet development. So you have to tell them that it is chronic. And I always say that it is the chronic venous disease. That means that it's chronic. That means that you are not going to heal at all. You're going to feel better. You are going to heal your ulcers and everything, but you have the predisposing factors to repeat again varicose veins, to have a recurrence. So I guess they have to do a lot of research about glycocalyx, because I think that's the main now. That's the main point to understand a little bit more the chronic venous disease. Because when I was studying at the medicine school, I remember even that when I was on the residence or the fellowship, I remember that they told me that it was a bowel problem and then hypertension, venous, and now we know that it's glycocalyx. And so we need a little bit more investigation about this. And I guess all the pharmaceutical, these huge laboratories, it has to do a little more research to give us the answer of the chronic venous disease. What was the first? Like I said, I don't know what was the first, the egg of the chicken. So we don't know what is the main problem in chronic venous disease, why they started, and why some patients, even that they are obese, they don't have even one little telangiectasia, and we have patients that they are very skinny, they do a lot of exercise, and they are full of varicose veins. So I guess we need more investigations about, predisposing factors in sex, gender, race, everything. We have to do more investigation about this.
Well, it's certainly genetic.
Yes,
plays tremendously, and I think that maybe our role is to also to go a little bit further with the patient that you have, that because we know very well that if patients are having the issue with the chronic venous disease, the probability that the kids will have the same is high. So maybe there is something proactive to be done for the following generation. Mm-hmm. And also I think that certainly we need to do something about our lifestyle, because it's for sure, it's whatsoever predisposition or not, it's related to our standing position. The fact that we stand up on two legs change our destiny, and it's certainly something to think about it. I don't know, they certainly right now you have all this tries about the working desk to be elevated to the standing position rather than sitting. But I believe also that maybe there is some culture to be created about the specific exercises to improve venous return. And that would be good, and especially for the patient and the family of the patients. That will improve with the little something added.
No, I completely agree. And actually, you can have two patients who are exactly the same, have exactly the same duplex in terms of venous reflux, and one of them has an ulcer and the other one has nothing. So there must be something beyond the hemodynamics, the acquired factors, and yes, the genetics in terms of obviously the twin studies show you that you've got, you're much more likely to get venous disease if your twin has it or your parents have it. But I think there probably is something about how the patient's own skin or own body deals with insults in terms of the hemodynamics or inflammation, then means that they're more likely to progress up the scale of chronic venous disease and maybe get ulcers, because that's one of the big things, isn't it, in terms of what drives progression and what drives ulceration and what drives aggressive recurrence in some people instead of others. And there's just so much more to do and to research. You're absolutely right. So it's a really exciting field to be.
Nutrition.
And nutrition. Yeah, no, absolutely.
Yeah, absolutely.
I mean, some of the ulcer work we've done, we found that carnitine was really important in helping healing, and that's been looked at in in animal studies and has been replicated in some plastic surgery work, and obviously it's a supplement that's given to athletes to enhance their performance and their energy metabolism. So there's something around all of that as well, that maybe the skin isn't just using the energy metabolism as well or as efficiently as it should do. But yes, lots of more work to do in the laboratory to help answer some of these questions. I think we're nearly out of time, actually. So I just wanted to really thank both of you for your contributions and your time. I'm absolutely thrilled that we've had both of you today. So thank you very much for your expertise and for this really interesting session where I've certainly learned loads, and it's been very helpful to me as a resident. Next time, so next month, let me just share my screen actually, if I can. So we will then have a session on recurrence, which will be on the 8th of January. And I really hope that everyone will be able to join us for that in due course. So thank you again to both our panelists today, and I hope everyone has a lovely rest of their Saturday and weekend.
Thank you very much. Have a good day.
Thank you. Bye.
Thank you very much. Nice to see you and take care.
Thanks. Bye-bye.
Bye.
Bye.